Good afternoon, and welcome to Bay State's annual Heart and Vascular Lecture Series. It is wonderful to see so many of you once again, and we welcome those who are new in attendance today. My name is Patrick Schilling, and I am the manager of Bay State Cardiac Rehab and Wellness Program, located at 3300 Main Street in Springfield. A few reminders about today before we get started. The first one is you can ask questions through the Q&A function, and we will review as many as possible at the end of today's presentation. We ask that you keep questions pertinent to our topics today. At this time, I would like to introduce Dr. Jared Ostroff. Dr. Jared Ostroff is the program manager of ambulatory pharmacy at Bay State Health. Dr. Ostroff is board certified in ambulatory care and geriatrics from the Board of Pharmacy Specialties. Dr. Ostroff earned his graduate degree, a Doctor of Pharmacy, from the Albany College of Pharmacy, and also earned an MBA from Western New England University. He completed training and residency as postgrad year 1 at Jesse Brown VA Medical Center in Chicago, Illinois. His postgrad year 2 was spent specializing in geriatrics at Durham VA Medical Center in Durham, North Carolina. Jared Dr. Ostroff is a clinical assistant professor of pharmacy practice at Western New England University in Springfield from 2013 to 2019. He has published in U.S. Pharmacist, currently is published in Teaching and Learning, and has written a book chapter for the Pure Pharmacotherapy textbook. He has presented at both local and national conferences. I would also at this time like to welcome Dr. Anna Mortali. Dr. Anna Mortali is a clinical pharmacist practitioner at Greenfield Family Medicine. She received her PharmD from the University of Rhode Island College of Pharmacy. She completed her postgrad year 1 in community residency at Bay State Medical Center. Dr. Mortali's postgrad year 2 was spent in an ambulatory care residency. She is board certified in ambulatory care from the Board of Pharmacy and holds a specialty certification in collaborative drug therapy management. Thank you both, Jared and Anna, for presenting today, and we look forward to your information.
Thank you for the introduction, and thank you for everyone for being here. As I present live from the Clinical Ambulatory Pharmacy Services Office, I'm at the medical office building in Springfield at Bay State Medical Center. And Anna is also presenting from New Mexico as of now, and she's away for the weekend, so I appreciate her being here as well. Really, all started about 5 years ago when we decided to take on Coumadin, or anticoagulation management, at Bay State, and introduce this new concept of a clinical pharmacist practitioner, really pharmacists who have advanced training and able to do a lot more than what your traditional pharmacist would do. This process from start to finish has been interesting. I know Anna and I are our first experience recording something like a promo. So I appreciate everyone who may have watched that on Facebook or Instagram, and there were multiple takes with that. Sometimes I think I forgot my name or I forgot who Anna was. So again, very interesting. And obviously, today is a big day as well, Sunday. I believe there's an Usher concert, and I think Taylor Swift is bringing her new boyfriend to play some sort of sport. But yeah, so our talk today, we're not necessarily going to be talking about medications or how they work. We're going to be talking about what is a clinical pharmacist practitioner, which may be a new concept for many of you, and how could they potentially help decrease cardiovascular risk throughout our various sites at Bay State. But before we jump into that, we need to start from the beginning. So kind of a little bit of a roadmap for today. We're going to talk about pharmacist roles, responsibilities, some advanced training, what is a clinical ambulatory pharmacist at Bay State. I'm going to talk through a few patient cases, some victories, and then maybe some opportunities and where we see all of this going in the future, and how you can help. So starting off with a little bit of a scenario, if we just pretend maybe that you or a friend or a family member experienced the worst week of your life, maybe a heart attack, week in the hospital, new medications, missed work, pages of discharge instructions. This is not an unfamiliar scenario. It's something we see commonly. The diagnosis at discharge now also includes heart failure. You may have some trouble breathing. Maybe there's some fluid in your legs, and there's uncertainty about what comes next. Surprisingly, you have an appointment in a few days in cardiology. How could this be possible? Perhaps you're pleasantly surprised to get in so quickly and don't understand how that happened. Arriving for your appointment a few days later, the front desk checks you in. The medical assistant takes vitals, escorts you to the room, and then you wait. Who potentially comes in? Is it a cardiologist, a nurse practitioner? Maybe it's a physician assistant. None of the above. You're about to meet what we call a clinical pharmacist practitioner. So the definition of a pharmacist, I've looked everywhere. One of the definitions is a health professional who has special training in preparing and dispensing prescription drugs from the National Cancer Institute. A pharmacist also dispenses prescription medications and provides information from the Bureau of Labor Statistics. Or according to WebMD, they're a healthcare professional who specialize in the right way to use, store, preserve, and provide medicine. And Anna and I do none of those things, so perhaps they need to revise the definition. If we think about pharmacists and just give some basic knowledge, so a pharmacist goes to school, they're in a 4-year graduate PharmD or Doctor of Pharmacy program. Some of the things that we do in school, we look at patient cases, we go through various simulations, we compound medications in the lab, we talk about therapeutics, guidelines, do some pharmaceutical sciences. We also participate in professional pharmacy organizations. After graduating pharmacy school, some folks can go work in community pharmacy, hospital pharmacy. Some of us choose to do things like residency or fellowship, which are optional. These are advanced training in any specific area. So ambulatory care, geriatrics, oncology, there's critical care and more. And both Anna and myself did partake in 2 years of that. And then once you finish that, there is an option to get what we call board certification from the Board of Pharmacy Specialties. And it really helps to kind of distinguish yourself as a clinical professional in the field, helps to hold us to a higher standard when it comes to knowledge, guidelines, and therapeutics. And then, of course, like any other professional, we do continuing education and clinical assessments and things like that. I mentioned ambulatory care, which is the setting that we work, but here pharmacists at Bay State work in all settings. So we do have a retail pharmacy, we have hospital, acute care, emergency medicine, critical care, oncology, and ambulatory care, of course. And the definition of ambulatory care is a medical service performed on an outpatient basis without admission necessarily to a hospital or other facility. So my team, or the CAPS team, or Clinical Ambulatory Pharmacy Services, all of us work exclusively in the ambulatory clinics throughout Bay State. We don't work on the floors, we don't work in the retail pharmacies, we are embedded in many of the clinics. Think about providers, patients, healthcare burdens, and barriers across the spectrum. Patient and other barriers, so location and transportation may be a barrier. Specialist referrals, sometimes if you go to see a provider, getting a referral to a specialist could be frustrating. Cost and coverage, that's sometimes barriers for providers, patients, and healthcare. As I talked about with the scenario, understanding the plan and what's next. Sometimes if you're being discharged from the hospital, you're seeing your provider. Sometimes from a patient perspective, that can be frustrating. And then fear of the unknown. So clinical pharmacist practitioners, a lot of times patients will get referred, or we will try to encourage providers to refer, and both the patients and providers may see that as barriers. And exclusively on the provider end, what we hear on our end at Bay State is the providers, physicians do not have enough time with the patients. And they're also unable to bring the patients back soon enough. So someone may have a new diagnosis of diabetes or whatever it is. Ideally, your physician would want to bring you back within a few weeks, but as many patients would be able to attest to, sometimes there's no appointments for months or even longer in some cases, or you just may end up getting referred to a specialist for management altogether. Our clinical pharmacist practitioners work within the ambulatory clinics at locations throughout Bay State. Some of their daily roles, we participate in what we call protocol-based care. So we have protocols that are written to allow us to manage and take care of these disease states as providers, including in diabetes, high blood pressure, high cholesterol, asthma, COPD, and smoking cessation. We are part of the team in these clinics, so we are part of team-based treatment. And we also work towards improved health outcomes and safety. What we find is that the CPPs in general reduce the overall burden and time on the rest of the team while increasing our access to care. And it's something we talk about a lot at Bay State is increasing access to care for our patients. This is the typical blood pressure, diabetes monitoring cascade. And it's what I use in a lot of my talks. And it's really where I see our opportunities as clinical pharmacist practitioners. If you're a patient in a practice maybe that does not have access to clinical pharmacist practitioners, you may see your physician for a yearly physical. Perhaps your blood pressure is elevated at that time. And the physician may refer you back, maybe to come back in 2 weeks for a blood pressure check with the registered nurse or MA. And at that time, maybe your blood pressure is still elevated. At that point, in most physician offices or practices, a message needs to be sent to your physician that has to be taken action. So the RN or whoever may notify the provider of the high blood pressure. The provider has to review that note. They have to review the blood pressure. They have to review your profile. They have to figure out which medication, what to do, what labs, and then they may send in a medication if necessary. After that, again, you have to come back and have your blood pressure checked. Oftentimes we see physicians may not have appointments necessary, so you may need to come back and see the nurse yet once again or whoever, and if it's still elevated. This may result in further med titrations, further provider time, until your blood pressure is controlled, labs ordered, and then you kind of continue on your own with controlled blood pressure. And again, I will revisit this later as we kind of figure out where our CPPs at Baystate fit into this model. Our pharmacists in clinical roles, there are several societies and organizations that have endorsed us in primary care. And one of them is the American Academy of Family Physicians, who wrote a 2021 article on how to integrate clinical pharmacists into primary care. Some of the roles that they mentioned would be chronic care management or even deprescribing, which deprescribing, it kind of seems counterintuitive, a pharmacist being in the clinic to maybe stop medications instead of starting. But we find, especially when we are working with our older adults, is sometimes their blood pressures are too low, or their blood glucose, if they have diabetes, are coming down too low. And as clinical pharmacist practitioners, we may need to stop the medications instead of starting more. And then the American Society of Health System Pharmacists in 2018 wrote that primary care pharmacy practice is the provision of integrated, accessible healthcare services who are accountable for addressing medication needs. And again, kind of gets back to that access. And so it's been a few years since I actually am embedded in the clinics and work with the patients. And so if you ask, what does an actual clinical pharmacist practitioner do? And this is where I will hand off to Anna, who will walk you through her role in the clinics and take you through some things as well. Thank you.
Hi, so my name is Anna. Did that work? Nope, too far. Okay. So my name is Anna. I am a doctor of pharmacy. I went to the University of Rhode Island College of Pharmacy for my pharmacy school, which is a 6-year program for me, which was nice. For my postgraduate training, I did do a year at Baystate in the community residency program, which was awesome. I spent a lot of time at different places around Baystate. So I got to go to High Street Health Center in Springfield, where we had hypertension clinic every Mondays, which was amazing. I also got to work with a geriatrician, so I got some specialized time with working with our older patients over 65. And then for my second year of residency, I was really lucky. I got to go to Rhode Island and work specifically in primary care with my ambulatory care residency. And as previously mentioned, I am board certified in ambulatory care as of this past few months, which has been great. And I do have collaborative drug therapy management certified, so I'm able to have limited prescriptive authority, which is beneficial for my patients. So I work at Greenfield Family Medicine, which is a bit north from Springfield, but we have 5 adult medicine doctors, 2 pediatricians, 2 nurse practitioners, a physician's assistant, 8 medical residents, which are great to work with, and I love doing education for them, and 2 mental health counselors, and 1 board certified doctor of pharmacy, which is me. So So what do I do? So as a CDTM pharmacist, I'm able to manage different conditions, mainly diabetes, high blood pressure, high cholesterol, newly added or smoking cessation and inhaler management. So think asthma and COPD for smoking patients. Some pharmacists are also able to do osteoporosis, so looking to do that in the future and expanding a bit. And patients are referred to me by their primary care provider in the same office, which is really convenient, so patients don't have to go to an outside specialist, which is what Jared was talking about earlier. So what does my day look like? I have patient visits. I do mostly in-person visits. So at these visits, we do medication management. I can stop, start, change medications. I can order labs for monitoring to ensure safe medication use. I provide education to patients. So we do a lot of talking about diet and lifestyle education and also medications as well. Given that I am a drug expert, I'm able to give a lot of detailed information and help make more individualized education and care plans for patients. And at the end of every visit, I send a note back to the primary care provider, so we're all on the same page and everybody gets to maintain continuity of care. I also do get some consults from other conditions from my practice, so I get questions from other doctors. And we also have a lot of focus on medication access and safety, and helping patients get medications at a lower and more affordable cost, which I have some help from my medical assistants in the office who are wonderful. So how can you be referred to me? Again, these are coming from your primary care provider, so they're in office. So this can happen during a visit, and your provider can say, hey, at the end of this visit, I think it would be a really good idea for you to meet with our clinical pharmacist practitioner, and they'll be able to work with you a little bit more frequently. Sometimes it can be identified via reporting data. If we look at certain A1C, which is a cutoff point we look at for diabetes, we can look at that. And provider can say at any time, hey, I think it would be a good idea, and reach out to the patient and let them know. You can also ask your primary care provider if you want to see a pharmacist, you want to get a little bit more information, education, get some one-on-one time. That's also available as well. So to give some examples of some successful patient encounters I've had since I've been at Bay State, which I've been back for only a few months now, since August. I had one patient, we'll call them patient X. I see them for diabetes, high blood pressure, and also COPD. So when I first met them, their A1C was 7.3. Usually we like it to be less than 7, so it's not a bad A1C, but still slightly above our goal. Initial blood pressure was kind of high, 170 over 90s. Usually we like it 120 over 30 is kind of an average, 120 over 30, 120 over 80 is kind of an average blood pressure that people will think of, but we like it less than 130 over 80. And for their COPD, they were needing an inhaler in order to go up the stairs. And so that's obviously not what we're looking for. So at the most recent visit, their A1C came down to 6.4, which is now at their goal of less than 7%. Their most recent blood pressure was 116 over 74, so under our goal of less than 100 over 130 over 80. Oh my God. And now for their COPD, they only need their inhaler once a month. I'll also add that their most recent cholesterol was 67. I don't recall what it was at the beginning, but it was way over 100. Goal was less than 70 for them. So over the 3 months that I've been working with this patient, we actually stopped a medication that wasn't working for them. We started a new medication for diabetes that ended up working a lot better for them. And we started 2 medications for blood pressure. We had 4 medication dose increases, and we also did a switch on the inhaler as well. And that's just all over 3 months. Okay, next I have patient Z, who I see for diabetes, high blood pressure, and polypharmacy. Polypharmacy is a fancy word for you take a lot of medications, usually more than 5, who is considered polypharmacy. So we look at those patients a little more critically to make sure all the medications are appropriate. So this patient, when I met them, their A1C was over 11, so almost 12, which is pretty high. Initial blood pressure, 136 over 88, so kind of close to our goal of what we're looking for. And their initial LDL was 145. For barriers, their medication for diabetes were just not affordable for them, so that was a big challenge for this patient. At the most recent A1C was down to 7.3, which is still slightly above the goal, but a big improvement from 11.7, especially over 4 months. And their most recent blood pressure was at goal as well. We also were able to have them apply, and they were approved for free medication through a manufacturer assistance program, which is perfect. So then they were able to be able to access their medications that were actually working for them. So over those 4 months, we did some titration with insulin. We increased blood pressure and diabetes medications, and we changed some of those diabetes medications as well and switched them. So what are the benefits of having a pharmacist in the office? So as I said, pharmacists are drug experts. We have specialized training for individualized drug therapy management. So especially for things like diabetes and blood pressure, where you can get a lot of different side effects that we're not looking for with medications, it's really helpful to have someone who's able to talk to patients and make sure that they're comfortable with the medications that they're taking. It's also an option for a longer and more frequent visits. I have more time in my schedule. I'm able to see patients more frequently. So if they were able to do medication adjustments and then get to their goals, hopefully quicker, which as you can see in my patient cases, over 3 and 4 months, we're able to make really good progress. The visits are also as I said, more available, and that frees up time for the other primary care providers to see more patients and address other needs and not just be able to focus on those one thing. And again, medication access and education is a big part of what I do every day, and it's what keeps me going. And I'll pass the mic back to Jared.
Thank you, Anna. Thank you for filling us in on how you're helping patients up in Greenfield. We've seen some great numbers and some great success up there in Greenfield. So kind of talking about what we call GDMT, or guideline directed medical therapy, and this is really what triggered us being here for Heart Health Month, was the work that Dr. Nicholas Simonich does in cardiology. About a year ago, we had started we trialed a heart failure clinic in Springfield. So Nick has been with us for about 4 years or so. He's board certified ambulatory care pharmacy, and he was unable to be here today. I believe he had some college visits with his son that he was going to. But he created, in collaboration with another one of his physicians there, a GDMT clinic for patients with heart failure. GDMT clinic is a little bit different than what Anna and the rest of them are doing, because it's getting them to target doses of selected medication classes very quickly. These patients who are coming out of the hospital with heart failure have severe symptoms. Sometimes they're having trouble breathing. And so getting these medication classes titrated and at the highest goal possible that the patients can tolerate it, that's the goal that we're trying to do. He has close follow-up, sometimes weekly or biweekly, with frequent medication changes and lab results. And he performs assessments and works with the medical team. The goal in his clinic is to improve symptoms and reduce admissions. One of the measures that he looks at is something called the ejection fraction. So what does this mean? Or it's also called EF, and it's the measurement of the percentage of blood that leaves the heart each time it squeezes. And typically the normal is 50 to 70% is what we would consider a normal EF. What Nick has observed in the clinic at first visit sometimes is 10 to 30%. And patients coming in with 10% a lot of times, or even up to 30%, just have trouble breathing going up a flight of stairs, or can't get out of the car and get into their house without getting out of breath. And so some of the patients that he's been seeing coming in with 15 to 20% starting EF, at graduation several weeks later, they leave with 25 to 30%. Some patients 20 to 25, getting to 25 to 30. He had one patient who started out at 25 or 30% EF and then graduated at 60 or 65% at graduation. And so what we're seeing over time in his clinic specifically is the patients who are coming in out of the hospital, either with a new heart failure diagnosis or significant symptoms, seeing Nick very frequently, they have improved symptoms, improved quality of life as well. And some of his big wins, I asked him to send me a bunch, and he sent me a lot. I just picked 2 here. So patient A was referred after they failed GDMT titration elsewhere for some reason. I'm not sure what the reason was, but this patient had a fear of low blood pressure, which is why they refused to increase doses previously. Nick, our clinical pharmacist practitioner, worked on really hydrating the patient to ensure the pressures didn't drop too low, and they were eventually able to work towards goal doses, increasing from 30 to 35% to 40 to 50%. And again, 35% to 45% or whatever it is may not seem like a lot, but when you're experiencing these symptoms on a daily basis, that could really mean improved quality of life. And then patient B referred after leaving against medical advice in the hospital, so the patient decided to leave themselves. They had trouble breathing in the chair, refusing to listen to any advice or change medications. Nick provided education on diuretics or water pills, some real life advice. And by real life advice, reading the note, Nick basically said that if you don't start doing this, it's going to be really challenging for you. And that's gentle words. Patient sent to the ED at that point for some IV treatment. And then that patient did come back to see Nick, started becoming more adherent medications, started some cardiac rehab, and then working towards the goal. Many times what we see in our GDMT clinics or our other clinics is it's not always starting the medication. It's not always titrating quickly. Sometimes it's having a pill box. Sometimes it's working on hydration. Sometimes it's just education. Patients a lot of times in the hospital have one priority, and that's getting out of the hospital. So a lot of times they're not listening at the discharge when it's like, okay, here's your 30 pages of discharge instructions. Here you go. Have a good time. Your follow-up is in a few weeks. And so our pharmacists in these settings are really providing education as well as medication titrations. If we circle back to our CAPS blood pressure or monitoring criteria or circle here, if we take that same scenario or a patient seen for their yearly physical, when their blood pressure is elevated, at that point, what we've done, instead of having the patient come back a few weeks later, maybe for a nurse visit or an MA visit, we're asking the physicians to refer the patient directly to our clinical pharmacist practitioners in CAPS or clinical ambulatory pharmacy services. So perhaps someone is seen in Greenfield and their blood pressure is 180 over 120. At that point, the physician may walk over and introduce them to Anna, or may just put in a referral to Anna. At that point, maybe a week later, 2 weeks later, Anna would see the patient, create a plan, maybe document, start the medication if necessary. And they may, like Anna said, send the physician a note just to let them know what's going on. But the key piece, the difference here from the first one we looked at, is there is no physician or provider time needed here. So the physician, once they refer to Anna, it's all on cruise control that we as the clinical pharmacist practitioners take care of. At that point, maybe Anna will start the medication, do some labs. We'll have a check-in by phone. She may reach out a week later and say, how's the new medication? How's it working for you? The patient may come in a few weeks later to see her again. Another med titration occurs, and so on and so forth. And eventually that patient is at goal. Maybe Anna decides to see them every 3 months or every 6 months or every year just to make sure everything's okay. But at that point, they can refer back to primary care and say, that patient you referred me 3 months ago, 6 months ago, their blood pressure is at goal, their diabetes is at goal. You don't have to worry about that in your primary care physician appointment. You can take that 20 minutes or 30 minutes and focus on helping them with other things, not going through all of their medications and doing these other things. So again, this scenario with your new knowledge, everything changes in this scenario that we talked about before. So having a heart attack, going to heart failure, seeing Nick in cardiology, perhaps meeting a clinical pharmacist practitioner. If we kind of run with that thought process, perhaps day one or 7 days after discharge, when you meet the clinical pharmacist practitioner, they may welcome you to clinic, explain their role, they work towards the goal. Maybe in GDMT clinic, they perform a fluid assessment or physical exam in some way. Maybe they do a blood pressure check and they order labs. They may also increase the dose of medications that were started last week in the hospital and providing education. At that point, you may come back a week later, where you're welcomed back to clinic by that same person who does another fluid assessment, blood pressure check, and ordering labs. And they may increase the dose of medication and so on. And then eventually, 28 days after discharge, your symptoms are improved, your medications are titrated to the max tolerated dose, and either Nick or whoever you're seeing with whichever clinic graduates you from our CPP clinic or our GDMT clinic or wherever you are, and they ask you to follow up with primary care and other specialists as indicated. Our job is effectively done in that case. We do have a daily huddle as part of our tier 1 or daily team meetings, and we do have a lot of victories from across the region. So again, I oversee the clinics in Springfield and Greenfield. Anywhere there's a clinical pharmacist practitioner, everyone is on that call every morning. And so I ask everyone to bring things like what's going well and their good catches and things that they saw. And some of those are that one of our pharmacist practitioners saw a patient with too many diuretic medications, too many water pills. And so they just reduced the dose of some of those, and their blood pressures at goal. Again, not adding medications. I think, Anna, that was yours. And then we had patients who A1C, or again, the A1C is a measure of diabetes, as Anna talked about, going from 14.4% to 8.1%. 14.4% A1C, I believe that's, what is that, like 500 or 600 glucose or something like that. That's very high. And your glucose or your sugar is really supposed to be less than 100 in the morning when you wake up. And that's, I don't even know if that's per the current guidelines. That's just I'm saying that. It's supposed to be around there. And so going from 14.4 to 8.1%, that is very significant. And blood pressure is going from 145 over 84 to 125 over 79. And again, A1C 11.9 to 7.1, blood pressures of 190 over 120 to 130 over 80. And then we had another one where there was a low blood sugar in an older adult and insulin was discontinued. Again, getting back to that, well, it's not always starting medications. Sometimes it's stopping them. But we can see that what we're doing in the clinics and what our clinical pharmacist practitioners are doing across the system are reducing overall cardiovascular risk, not necessarily by in the hospital or anything like that, but by optimizing medications, helping you as patients to optimize and take your medications, figure out when maybe troubleshooting and things like that. Obviously, these are great services, and In the past 4 to 5 years, we have continued to ramp up. I was the first clinical pharm practitioner about 5 years ago, 4.5 years ago, and we have kept growing. So we are at Bay State Cardiology in Springfield. We are at the primary care practices in Northampton, Longmeadow, and Palmer. We are at the Brightwood Health Center in Springfield, Greenfield Family Medicine, High Street Health Center, and Mason Square Neighborhood Health Center as well. So we are in various locations already embedded into the practices. So what, if we think about everything we've learned as a wrap up and future direction, clinical pharmacist practitioners can help patients, providers, and medical teams increase access to care. Again, we started this journey 4.5 or 5 years ago, really to increase access to care for patients. We continue to hear that physicians in primary care were overloaded and they needed help, and so we're here to provide that help. The team dynamic has been slow to change, obviously. Patients here, they're being referred to a pharmacist, or I'm going into the practice and saying, please refer to our pharmacist. And everyone is still very confused about why we're still in the room at all, or why we are in the practices. But we're slowly working on changing that culture, working towards embedding additional CPPs into the practices. And we're also working to expand our pharmacy residency program, which if there are any pharmacy students who were invited today and they have attended, we are starting a PGY2 ambulatory care residency program to provide that advanced training and hopefully continue to provide a great education environment. So again, kind of a call to action as well for patients and everyone across the spectrum is consider asking to see a clinical pharmacist practitioner at your next Bay State appointment. Even if there's not one present at your office, that may trigger some conversations above in senior leadership that either Anna or myself or my bosses may get pulled into. Well, we may not have been able to see a need here, but all of a sudden, all of these people are asking to see one, and there is a need. So maybe that will help point us in the right direction. So again, just want to thank everyone for logging in today. If there are any questions, Anna and I will hang out. We're happy to answer anything that we can.
Thank you, Jared, for extremely informative talk and so exciting to see both you and Anna's work in the clinic and how you're reducing cardiovascular risk. I just wanted to mention that if you do have a question, to just please pop it into the Q&A and we will address it to either Jared or Anna. I have one question for you, Jared, and that is often in cardiac rehab, we get patients after discharge that have a medication list, but we often see that medications are being added to patient lists, but there's very few reconciliation happening where medications are active medications are actually taken off a list or written as discontinued. Can you describe like best practice for patients as to how to get meds off the list that they no longer take?
I feel like that's more of an Anna question, right? So yeah, I'm gonna pass it over to her.
Yeah, I actually end up getting a lot of patients that for an ED or emergency department follow-up or a hospitalization follow-up. So I do help with those as well. So I really encourage patients to become involved in their healthcare if they're able to, and keep a list of their medications with them and bring it to each visit with them. And really just staying on top of it that way is probably the best way to avoid medication errors, and just being in good communication with your providers as well.
Thank you. That's wonderful.
I also just wanted to say thank you to everyone for coming today. It was really great to speak to all of you.
I have one other question for either one of you, and that is often I get asked the question about, say, like statin therapy. People are asking the question like, oh, should I be on Lipitor or should I be on the generic? And what's the guideline from a pharmacy perspective as to which is better, or what are the pros and cons both?
Yeah, I'm usually very comfortable with generic medications. I don't use brand unless brand is the only one that's available. Typically, if patients experience a negative effect with one statin, we can usually just switch to another generic statin. Statins are very cheap. Because they're generic, so they're very affordable. Brand name medications tend to be very costly, so I typically try to avoid that for my patients, especially when other medications are already so expensive.
And I have one other question for Jared, which I'm quite fascinated by this concept of clinical pharmacist practitioner. How did that get started at Bay State, and when did it get started?
So, I mean, it really started with Coumadin, or anticoagulation. You know, five years ago, before I came over, it was decided that pharmacists would start the process of taking over Coumadin. And that's, we lived at 3300 Main Street for a while until we moved over to the MOB. And as we started the credentialing process and as we established ourselves as able to prescribe, I had continued to advocate for us to do other things. So blood pressure, diabetes, everything. And so I had did a pilot probably about 2 or 3 years ago with Northern Edge Adult and Family Medicine, and I had monitored patients, their blood pressures. We had sent them monitors at home. I had adjusted their medications, and it was really just a kind of a proof of concept at that point that, answer the essential questions: can clinical pharmacist practitioners successfully manage and work with the other team members to help patients achieve their goals? And once we achieved that, once primary care saw what we were able to do, I think it just it took off from there. It just everyone started, asking for the services, and we are continuing to grow, obviously, all the time, and finding the right places and things like that.
I have a question in the Q&A that says, are appointments covered by insurance?
Yes,
Absolutely.
they are.
Yeah, exactly. Yeah, so we're working in the clinic spaces. It's a complicated question and answer because Anna is in a Greenfield Family Medicine, which is technically, if you would consider Part A space or hospital space. So insurance is charged, but it appears more of like a facility charge, not a charge from Anna herself, unfortunately. And that could be a whole other hour talk of itself. Pharmacists are not considered providers as per Medicare regulations from like 100 years ago, when it wasn't 100 years ago, but it was a while ago when everything was written. We were not written as providers. So we are not able to bill under our names, but the bill does get submitted as a facility fee.
And also, when I do my phone follow-ups, like if I do a check-in and ask how a medication's working for a patient, those are not, you don't get billed for that at all. That doesn't even go to your insurance. That's just for free.
Wonderful. I have a question from James in the Q&A, which says, can you further discuss what a fluid assessment is and how it is performed?
So it's typically done by Nick in heart failure. And Nick, I see that you're logged in, and I'm going to try to discuss what you do. And if you're able to correct me at some point later on, or tell me that I was wrong, feel free to do that next week. But Nick brings the patient in. He has them sit down. He does a visual assessment of specifically, I believe, in their legs or their ankles to see if there's any sort of fluid. So he will take, I guess, like finger, right? So he'll take a finger and he'll put it on your legs and assess for what they call lower extremity edema. And in certain cases, when we're learning about fluid status and things like that, it can be considered like +1 or +2 or +0. And that's how he will do a fluid assessment in the legs. And based on that assessment, he will prescribe the appropriate diuretic that is necessary. Anna, do you have anything else to add to my basic explanation?
No, I think that was pretty good.
And if that was another, I'm sure Nick is going to yell at me next week. So
this is great discussion, and I have a few more questions in the Q&A. This next one is from Katie, which states, can clinicians reach out to you directly with questions on patient medication reconciliation?
Yeah, so I actually do get those requests, and I have met with patients specifically for polypharmacy, which is, again, being on multiple medications, just to do an assessment and check everything, make sure there's no drug interactions or any side effects that are bothering patients, or if there's a way that we can optimize it and change like a twice-a-day dose to a once-a-day or to a less expensive medication. So there's a lot of different things that I can do for that, and that's one of the more fun things that I get to do, is going through the medication list. But yes, the people can ask that.
And one of the things that we do talk about in our huddles that comes up is that a lot of the team will sometimes ask, oh, can we see someone for just polypharmacy or adherence? And we always just say, have them referred, have the conversation, because a polypharmacy or an adherence visit or something like that is never just a polypharmacy or adherence visit. It's always something else. So the patient may be referred because, oh, we're not sure about the adherence or whatever, but then in the visit, their blood pressure is elevated or something happens where we end up kind of taking them on the panel and we end up fixing other things as well. So it's always just best to have the conversation and see if maybe there's areas that we can help.
Yeah, and sometimes it happens organically too. Like I'll be seeing a patient for diabetes, we're talking about exercise, and then they're saying that exercise is really hard for them because of their breathing. Now we're talking about their inhalers, and it's a whole other thing. And then it ends up being really good for overall.
I have another question in the Q&A. This is not directly related to a clinic, but maybe a department within Baystate. I'm not sure if you're comfortable answering, but is this pharmacist available at BMC ER as a patient in cardiac arrest is brought in?
So we do have pharmacists in the ER. They're not part of my team, but they are. We do have an emergency medicine pharmacist, and we do have emergency medicine pharmacy residency too. They are present there, as well as we do have pharmacy technicians working in medication history to ensure that when you come into the ER, medication histories and what you take are accurate. So I did get to observe a little bit of that when I covered that service last year, just the medication, the pharmacy technician part of it.
Yeah, that's one of the things I really like about Baystate is there's pharmacists in a lot of different places. So they are invisible seemingly, but they're very helpful.
At this time, I don't see any more Q&As. I would like to thank all of our attendees today for taking time out of their Sunday to learn a little bit more about what pharmacists do here at Baystate Medical Center and the role of heart health. I'd also like to thank Dr. Ostroff, Dr. Mortali, for joining us today and sharing their knowledge and expertise. We really appreciate it. Thank you, everyone, and have a wonderful Sunday.